I'd like to reintroduce Dr. Levin. She won't have a special descriptor this time, but she is going to speak to us on a continuation of an emerging sub-theme for this meeting, provincial and international perspectives on chronic kidney disease care. So I think she's well suited to give that address, and please welcome her.
Thank you. So it's really my privilege to be able to give a talk about global perspectives in chronic kidney disease, and I'd actually like, in our usual way, to actually describe and go through some opportunities and challenges that I think we all have as the nephrology community to improve outcomes around the world. And many of you will know that I spent the last couple of years in some roles at the International Society of Nephrology, the most recent of which was the president. And so I got to see a lot of things, and I'd like to share that with you because I think we have a lot that we can do in BC to contribute to that. So my goals for this presentation are really to very briefly describe the current state of chronic kidney diseases, and the S there is very specifically because, and I remind the residents and fellows this all the time, chronic kidney disease is not one thing. There are many diseases that cause chronic kidney impairment, and it is a public health problem to different degrees around the world. There are many opportunities and challenges. I'd like to review with this audience some of the International Society of Nephrology and related initiatives and programs to maybe stimulate some thought. But mostly what I'd like to do is stimulate discussion, perhaps a little bit in this room, but more importantly when you leave the room, to continue to talk and ask questions about how we can help around the world. So we do know that chronic kidney disease is a public health problem, but it's due to different causes in different locations. And World Kidney Day and various different organizations have different ways of graphically demonstrating this so that it's more accessible to the public. And many of you in the room are too young to remember the time where this never appeared on a public bus or format, but it is now much more accessible to the world at large. Sadly, chronic kidney disease as a cause of years of life lost has moved from 37 to 25 in 1990 and to 17 in 2015. That's not something that I think we should be terribly proud of, but it may be an increasing recognition of the importance and people identifying chronic kidney disease. And this is from the Lancet Global Burden of Disease, a large group out of Seattle, the International Health Metrics and Evaluation group that's sponsored actually by Bill Gates in his attempt to understand global health better. And it's an interesting thing to see that we actually have raised up. However, perhaps that gives us more pause to do things about it. And in that same global burden of disease report, interestingly, 1.5% of the total daily disability adjusted life years is actually attributable to chronic kidney disease, and that's been growing annually at about 1%. So that means it's not just that it's a bad thing, but disability adjusted life years are actually adversely affected by kidney disease. No matter where you look, there are international estimates of chronic kidney disease, and they're consistent through countries between 10 and 16% of adults. And there are a lot of people that say, well, you know, you're measuring it wrong and GFR is perhaps too sensitive. The fact that it's consistent really worldwide, no matter what country you look at, is something that I think is important for us to look at. And on your right is something from Cello Tonelli in Alberta, and on your left is something that was in PLOS One. More recent update, and the prevalences, interestingly, are very similar. And when you look at newer estimates, something that we described actually quite a while ago is the variability. And so while they are consistently double-digit, there's certainly clearly some variation in the global prevalence of kidney disease, depending on where you look. So this is a systematic review and meta-analysis of 100 studies of very different quality, but about 6 million people. And depending on what stage you look at, you have ranges, and I've just highlighted in yellow there for you the different stages of kidney disease and the different prevalences depending on the different countries. And the scatter plot to your far left is just that same slide from the one before. Beppe Ramuzzi under an ISN kidney disease and large cross-sectional study, actually went to 12 countries in 6 world regions and systematically collected individual patient data around screening programs and high-risk clinics. And interestingly, in general populations in those countries listed there, it's around 14%. And in high-risk populations, those with hypertension and diabetes specifically, around 36%. And that's with direct screening, measurement of urine and or blood work. And unfortunately, the awareness in all of those countries in general populations is low, about 6%, and in high-risk populations, not that much better, as in 10%. It's also low for other diseases, but not quite to the same extent. If you look across Europe, in Norway, as compared to Northeast Germany, whether you look at stages 1 to 5 or 3 to 5, the prevalence of kidney disease is very different. And one could invoke all sorts of things, including genetics, diet, lifestyle, et cetera, and also healthcare system issues. But it remains interesting and certainly an area of future study to understand what these different prevalences are about. Now, some of the drivers of kidney disease are important to think about. So worldwide, diabetes and hypertension is increasing around the world. In low and middle income countries, there's a rising middle class, and with that comes an decreased exercise, increased access to food that isn't necessarily indigenous to the region, and a lot of obesity, which drives both diabetes and hypertension. And in fact, this is taken from the diabetes awareness campaign, but in 2014, 387 million people had diabetes, and it's projected in 2035 to increase by 53%. And sadly, most of that is in Africa, in the Middle East and North Africa, and Southeast Asia. And so in countries that are ill-equipped to address this major problem is where you're going to see the greatest rise of diabetes, and therefore the implications for kidney disease, I think, are really quite profound. So the other clinical problem that we have is that while we have renal replacement therapy available, it's only available to the most fortunate in most of the world. And this is a world map that disproportionately demonstrates to you where the absolute number of people who die of kidney disease because they don't get renal replacement therapy. And so you'll see that Africa and South Asia and Europe Eastern Europe is where people die, and in North America, we don't die, and in certain very privileged countries, we don't die. So people don't receive renal replacement therapy, and this is done out of the George Clinical. It's a very nice systematic analysis, and they estimate that between 2 and 7 million people per year that require dialysis do not receive it. And it's due to a number of issues, mostly poverty, as well as healthcare system problems that are in different countries. So between 1/4 and half of the patients that need renal replacement therapy actually receive it. That's reason for pause when we live in this province where everybody who wants it gets it. So there's variability in prevention and treatment and access to those things. There's variability in access to dialysis, and along the theme of this morning, access to transplantation. And really importantly, there's also access to trained teams of healthcare providers, not just nephrologists, and that is really quite different around the world depending on where you look. So these are older data that looks at end-stage renal disease in the purple bars. This is in Europe, and as you might imagine, in the tallest bar, that's Germany, and in the smallest bar is France and Italy. And so they have similar healthcare systems and yet do not necessarily have similar rates of take-on to dialysis. And within Latin America, relatively poor and thought of as low middle income, PD, which as you've heard from many speakers is a much more cost-effective option, is hugely variable across the Latin American nations. So there are other drivers of why people are on specific therapies. People have tried to study access to care within and between countries, and there's no question that geography and race are part of the drivers in this country. Our Indigenous people have less access to dialysis and transplantation than non-Indigenous people, and Jag already showed you the difference in donation rates in terms of transplantation, both living and deceased. So there's a recent article that you might want to look at in the Lancet that we wrote on ethical issues in dialysis therapy, because I don't think it's just about making dialysis accessible to everybody around the world because there are perverse incentives in certain countries where you can make money from dialysis, so then you don't need a transplant program. And so one has to be quite careful about what you're wishing for. So what you really want is prevention and a continuum of care, not just advocating for access to dialysis. And that's an interesting ethical discussion to have. And within this province, Canada, and internationally, there's a large group of people looking at the Declaration of Istanbul, and that's defining travel for transplant and safe practices and really trying to shut off this traveling and purchasing organs in other countries. And that still goes on in this country and in this province even, but we actually now have a watchdog thing where we actually are now reporting those, and Canada's the first place to have a registry where people who go away to buy a kidney and come back are identified and put into a registry as having purchased an organ. They get the same care because that's what they're entitled to as Canadians, but we actually are beginning to try and quantify that major issue. So at the International Society of Nephrology, they have a new vision statement, or we have a new vision statement. And all of you who are Canadian Society of Nephrology members, by the way, are also ISN members. And if you're not, you can sign up as an associate member. But it's a future where all people have equitable access to sustainable kidney health. And very purposefully, the word disease is not there, because the actual answer to this particular worldwide epidemic really is to actually sustainably maintain kidney health so that your need for dialysis and transplantation is mitigated. So it's a philanthropic organization that tries to bridge the gaps of available care through advocacy and collaborations, to build capacity, and to connect the community. And in a way, this meeting, which connects community within BC, but also with our other Canadian provincial colleagues, as well as our international colleagues from Hong Kong, Sweden, and other places, hopefully that actually we are attempting to ensure that we truly bridge these gaps, connect the community, and really build capacity with all the training. So if you think about what we've accomplished in chronic kidney disease and look at it as a global health problem, we have a definition classification system, which while not perfect is a not bad start. We have increasing awareness. We have a growing number of consortia and collaborations for both basic and clinical science. And we have some new therapies for treatment for things that we didn't ever think that we'd have new therapies for IgA or membranous or vasculitis or any of these things. And so we are getting somewhere. We have now much more emphasis on genetic and molecular mechanisms, so we're understanding disease processes, which should lead to new discoveries. But we still have huge gaps in our knowledge, right? We don't really understand all the mechanisms of disease, of the different diseases. And when we do clinical trials, we're not very good at figuring out the responders and the non-responders. We keep trying to look as if everyone needs to respond to the one drug, whereas we know in every other disease that's not the case. We're studying, but not as well as we perhaps could, genetic and environmental interactions. And I think, sadly, there's been a reduction in the number of people interested in nephrology, whether it's nursing or medical pursuits, because of some of the limited possibilities that we have to actually influence the course of disease. We've had a number of failed clinical trials that end up being published in very high-level journals, and so people get a little bit discouraged that there's not much we have to offer people. Hopefully we're changing that with the new SGLT2 inhibitors and some other things, but it's been a slow time coming. We don't have a lot of mechanistic targets that we've identified. And at the end of my talk, I'll see if we can change in here the culture of clinical trials and inquiry so that we actually all together understand why it's important that we participate in all kinds of observational and clinical trials for the betterment of everybody. So we understand I've showed you at the beginning some of the epidemiology of the various diseases, but we still don't understand what really drives that variability in incidence, prevalence, and progression. We spent a lot of time talking about how precise our measurement of kidney function is, and I must say that I'm a bit bored of the discussion of which is the right equation, because I don't think it really matters that much. I think it's really, what do you want to use the estimate for, and is it for clinical research or advocacy purposes, and what is meaningful change in kidney function? When we think about interventions, we have systems and therapies, and we probably haven't looked at the interaction of those two. And we really need, as I said, from a research perspective, to think more about generating the evidence base, and then when we have it, to actually implement evidence-based care and really participate in all trials. And that includes not just high-income countries, but also low-middle-income countries. So I had the privilege of actually chairing a global health summit, the first ever, and we had it in Vancouver in July of 2017. I guess it was only that long ago. No, July of 2016, and we published it in April of 2017. And what we did is we created a roadmap for how we might close these gaps in care, research, and policy. And it was an international meeting that we held out at the UBC campus, and was really an interesting group of multiple stakeholders, policymakers, researchers, industry, clinicians from around the world to truly and come up with a set of key messages which were about the things that I've already talked about: collaboration, having a better understanding, using existing data sources. So we have a lot of trouble sharing the data that we've got, and how can we do that in an efficient and effective way? How do we expand the clinical and the research workforce? Because without both, we won't get anywhere different. And as I said, and we'll keep saying, increase our evidence base. Most importantly, this group of people realized that the notion of a performance measurement framework, how do we stay accountable to the general international community of patients, that what we're saying we're going to do is actually going to make a difference, and how to be transparent about that. And so if you haven't read this, it's actually a real tour de force by a number of amazing people from around the world we spent a lot of time thinking about all of this in the various groups. In addition, we created the first ever Global Kidney Health Atlas, and that was published in Précis form in JAMA in April of 2017, and in Kidney International Supplements will come a series of much more in-depth articles about this. And importantly, this Global Kidney Health Atlas looks at assessing kidney care on the 6 dimensions of universal health coverage. Does everybody in this room know what universal health coverage is? Put up your hands if you do. So this is what the WHO says is our goal for the next millennium, is that we really need to have accessible universal health coverage. And what that means is that you have access to healthcare workers, to treatments, to medicines that we know are effective, information so that you can actually make decisions, and health policies that actually provide prevention as well as diagnosis and care. And I guess most importantly, the funding within every country to make sure that you can promote this. So what we were curious about is whether or not we could actually identify the gaps in care using those 6 dimensions. So using the ISN regional board structure, highlighted here in all the beautiful colors, we actually surveyed 125 countries with a 96% response rate. So we cover 93% of the world population. We did the survey with a robust survey methodology in 3 languages, English, French, and Spanish. Why, you ask? Because we were asked our regional boards, and they said that those were the only 3 that they needed. And so we now have baseline data for all regions, countries, and globally. And I thought you'd be interested to see some of this data, because it really talks about country capacity and readiness and response for optimal kidney care according to those domains of the universal health coverage, and actually allows us as a nephrology community to think about strategies and policy frameworks and how we actually develop research and capacity for it. So if you look around the world, and I'm going to go through this relatively quickly because mostly it's you'll get the gist of this. Basically, we're not very good at understanding CKD, dialysis, transplant, and acute kidney injury around the world because we do not have registries in all locations around the world. So on the vertical axis are all the 10 ISN regions, and then the percentage of registries that exist in those locations is there. So very few places have CKD registries. BC is one, but Canada as a whole does not. Dialysis, it's not 100%. You would think that governments would want to know how many people are on dialysis. Not so much. So hard to advocate for better care if you don't know how many people are on dialysis. Transplantation registries exist in North America, Northeast Asia, but not even 100% in Western Europe, which we all think of as a developed world. And AKI registries obviously are even less prominent. If you look at the global distribution of nephrologists and rate per million, as you may not be able to read this, but basically the larger your country, the more your people, the less nephrologists you have, which is sad. And so overall in lower, there are 8.8 nephrologists per million population overall, and the trainees are at a very, are even a smaller number. And then by level of income, low income, middle income, upper, middle, and high income, as you can see there are more in the higher income countries, despite the fact that there aren't necessarily that many people. So this is density. It's the same data just shown in other. The most number of people are in North America. The smallest number of people are in South Asia. This is not just nephrologists, and you won't be able to read it, but again, you can see the variability of all the bars, but this is social workers, dietitians, nurses, educators, and I can't remember all the other ones, but it's the entire team. So we thought it was very important to figure out if the teams exist variably around the world, and certainly, as you might expect, they do. When we looked at what do you need to actually identify and manage chronic kidney disease in primary care, and you'll see this is a spider diagram. So blood pressure, you have to be able to measure blood pressure, height, weight, glucose, A1C, it's cholesterol, and sort of go around the wheel. So in the blue line is low income countries. And what this actually describes to you is that in lower middle income countries, we can't even identify chronic kidney disease, let alone manage it in many places because they don't even have the ability to measure serum creatinine. Right? So how can you possibly prevent something if you can't even identify it early? And if you look at secondary care, a series of things that you might need to understand better, things like pathology services and radiology services and ability to dip a urine for an ACR, never mind look at it under a microscope. Again, you see the same pattern with the blue spider web in the middle having the least number of these things accessible. So no primary care, no secondary care, hard to identify and manage this problem. Similarly, we looked at the availability of renal replacement therapy. And importantly, when we presented this at an international group, people reminded us that having something available doesn't mean it's accessible. So in some countries, it's available, but you have to be rich to be able to get dialysis. Example is in Africa. It is available in many countries, but it's not accessible to everybody. And so again, you get the picture here of the huge variation. The different colors are acute PD and acute hemo, chronic and PD and chronic hemo and transplantation. So not everybody gets access to everything, and paradoxically, some places have acute PD and acute hemo, but no chronic. Can you go back one, please? So if you think about one of the cornerstones, rightly or wrongly, of something that we know delays progression, the availability of ACE inhibitors around the world is not uniform. You would have thought at pennies a day this would be much more available. And if you look at the coverage of chronic kidney disease medications around the world, similarly in the different places, the coverage is different. And you'll remember the universal health coverage domains are that essential medicines be covered by the country. And so this becomes a stretch goal for many of these places where there's perhaps a change that they can make. And then what's covered in the healthcare system, as you can imagine. So if you don't have AKI covered, then you don't even survive your AKI episode. Non-dialysis CKD, believe it or not, is not covered in most places. Dialysis and transplantation are similarly variable. So just a snapshot into the way that it looks like. Clinical practice guidelines for kidney care, similarly variable. And by region, CKD and AKI, again, not necessarily with huge uptake. And in terms of organized advocacy within countries for kidney care, believe it or not, because we get very spoiled in British Columbia and in Canada, where we actually think this is kind of just the way you do business, is you just take care of things. There are only organized CKD advocacy in 42% of countries around the world, and for AKI resources in less than 20%. So the capacity for research, as you might imagine, if you want to group Western Europe and Latin America and overall, you'll see that for health services delivery research, again, a limited capacity worldwide. And this is just 2 major regions, which again limits our ability to move the science forward if you actually don't have capacity to conduct research. And from all of this data, we created a kidney care scorecard. And you can see it listed on the website as well as in the publication. It's alphabetical by country, and then each of the different things that I've shown you before. But I think it's just an important starting point. And as we implement different things around the world and socialize this information more, then we're hoping that some of those red boxes turn into yellow boxes, turn into green boxes as the world actually changes a little bit. And sadly, if you just look at what the grouped according to World Bank country, funnily, the governmental, look at the third bar, the governmental recognition of chronic kidney disease as a health priority is really high in low-income countries, and in high-income countries, not so much, 29%. And that's because there's so many other things that are competing. So paradoxically, some places like Sri Lanka, it's a national health problem. In India, it's a health problem. In China, it's actually up there as one of the top 3. And yet in places like North America, it doesn't come up on Justin Trudeau's lips very often that kidney disease is a problem. So we demonstrated a lot of inter and intra-regional variability, and it gives us a lot of ways that we can engage in the research that we do and the importance of including all ethnicities in the research that we do so that we can inform care around the world. So, kidney disease from a global perspective is common, harmful, and treatable. It's linked to other things like diabetes and hypertension and cardiovascular disease, but I've shown you a little bit about the variability and approaches between and within countries. And I think we all understand, but probably haven't studied as well as we could, the role of the healthcare systems in prevention and control and in integrating. So we really need to work together to have a better understanding and a bit of a unified advocacy approach and recognize really the diversity of the human condition, but importantly look at the perspectives of patients, providers, and funders, because that's how you make cogent arguments that are actually sustainable over time. So many of you know that I'm a bit of a harper on the need for better data, and there's better data that you can get from lots of different places: registries, collaborative work, clinical trials, observational studies. And the more we do this research, the better we're able to describe, the more we're able to understand mechanisms, and the more we're able to understand, if you intervene, what works in whom, why, and why it doesn't work. And that's how you move things forward. So I think we need to explore a commitment to better understanding and really think about all the different kinds of studies: descriptive, well-designed physiological studies, and large clinical trials, because no one will answer everything, and you need the combination of all. And this is not to exclude basic science, but really to sort of give a higher level overview. Sadly, when you look at world populations in clinical trials, the access to medications and the conduct of clinical trials in lower middle income countries, again, out of over almost 3,000 clinical trials registered, they're mostly in Europe. They're not in South Asia, Africa, India, and China, and they are outnumbered by the ones in Europe. And sadly, the medication access gets caught in regulatory issues. There's issues with adherence and monitoring. And so how do you actually change that? If where your people are is not where you're conducting the research, you may have a huge other gap. So I'd like to challenge us to conduct clinical trials worldwide and think really about this weird paradox that the amount of resources that are being spent for the treatment of kidney diseases is massive, but the evidence on which to base and inform clinical care is so little that if only we could readdress, we might actually be able to do things differently. So I think clinical trials are really important to inform care and therapeutic strategies. We can build on all of our collective experience. And the main requirements are really number of patients, having a protocol that you can adhere to and make sure that you can get the study outcomes and have good statistical analyses. And size is important, diversity and generalizability is important. And in the meeting this afternoon with the nephrologist, I'd like us specifically to suspend disbelief and remember that we don't know the answer to most of the questions. And when there are clinical trials for us to enter into, we should really be very excited about entering our patients into trials as opposed to believing that we actually know what the right answer is for that individual patient, because most experts don't seem to know the answer. It's hugely challenging to conduct clinical trials, and there's a whole science where people are trying very hard to simplify things, think about large pragmatic trials, enroll people differently, and measure outcomes in a much more simplified way for data collection and analysis. Importantly, you need to train people to conduct the trials, and we're fortunate in BC to have a growing group of people who are able to actually conduct the trials, select the suitable population, and have really simple data collection. And so those are some efforts that are going around, both in Canada, in some of our partners in Australia and the UK, but also in China, South Asia, and other places. There's a really nice article in New England Journal in March of last year that you might want to look at, which is really changing the face of informed consent and really coming into the 21st century a little bit and having electronic and digital. Not everybody can read and write, so giving people a 7-page consent form to sign them up for a study doesn't really make that much sense. But if you had a digital one where you could interview them, explain to them, and they say yes, then that should be perhaps better and more real than this piece of paper that people sign. So there's been some studies on the uptake of that. There's a huge amount of changing research methods, looking at internet-based trial recruitment, patients coming forward as opposed to us finding patients. And with the change in information technologies and apps and other practices, we might really be able to conduct clinical trials in a very different way that would actually allow us to get the answers to big questions much more simply. So we have a huge opportunity as well as a challenge, and the opportunity is, I just showed you all the huge numbers of people living around the world with chronic kidney disease. Some of those will access clinical trials as a secondary gain to get access to care. Maybe that's not a bad thing. You can show that it works. But there's still really an unmet need, and there's a number of challenges, not just in lower middle income countries, which I've put on this slide, which is the poor infrastructure, et cetera, but even in our own country and province where it's not as simple as you might like to be able to enroll people into studies. I'm just going to skip that. So we do have this large number of people. When you talk to the patients and their families, they're very willing. They really would like to know more about clinical trials. And with social media, we have the opportunity to allow them to self-register for studies if they're eligible. And that might be something that we look at in the very near future in this province. And there's a growing number of networks. International Network of Chronic Kidney Disease Cohorts is an ISN network. ISN Acts is Advancing Clinical Trials, Awareness, Education Opportunities. There's the Oxford and George Clinical Trials Group based in the UK and Australia, respectively, and a number of patient-oriented research initiatives with a kidney focus. So I think that the future is a bit brighter in terms of our ability to really conduct and look at clinical trials in chronic kidney disease. So the ISN actually awarded 81 clinical research grants since 2005. The development of INET, CKD, and ACT, and H4KH, which is Hydration for Kidney Health, is an initiative with Danone, which is a company that makes water, or distributes water. And really, these are all ways that we're helping to develop partnerships to try and get things moving in a very different way. We've changed the paradigm, so now we're doing large pragmatic trials. We use administrative database for randomization, which would be also much simpler than what we currently do, and trying to design trials with simple follow-up and interventions and meaningful outcomes. So if you think about how we as a collective can have an integrated approach to improve kidney health, it's through research, through advocating at the policy level, through alliance building with with the different communities, through outreach in terms of us visiting other countries and locations, and through mobilizing patients, their families, and the healthcare system in a really effective way. So what I'd like to give us a challenge is to tip the balance towards a more evidence base and to look at all the opportunities that we have to really improve the care of patients living with kidney disease. And I think if you think about all the activities that are going on, the basic science and translational consortia, all the patient-oriented research consortia, these collaborative clinical trials and networks that are developing, we should be and are developing new knowledge and new paradigms, and that should lead to new policies and dissemination in a very real way that we can only do if we all do this together. And so there are many medical advances and innovations going on around the world, not just in the kidney space. We have lots of guidelines and standards of care, and again, proudly, I think BC is leading the way in many of that. And with some renewed excitement about research and data collection and some political will, we might truly be able to achieve better global kidney health. So what I'd like to do is leave you with the thought that there are certainly multiple opportunities and challenge to inform and to improve care worldwide. I think in BC, we're privileged to live in a place where we never have to think about who can't have things, and yet at the same time, we actually might be able to disseminate some of our knowledge to those other countries. And I think I'll end there, and thank you very much for your attention in the postprandial state. And I'm ahead of schedule. So we have
Yes, thank you. We've got some questions online. Again, welcome to anybody for the mic, and we're in the nice luxury here of having time to have a good discussion. One of the questions that came in is something that I think about and grapple with. I think it's probably something that we all deal with every day. You want to do more. So what role can an individual play in enhancing global equity in renal care? That's just a beautifully worded question.
So as individuals, I mean, I think many of us are privileged to travel through ISN and various other things. We can hook you, if you want to go and travel to Namibia and see kidney care there and offer as a nurse, dietitian, social worker, or physician, either expertise, observation, or just a pair of hands, the barriers for us doing that are very little. There's way more barriers to bringing people here. We have the opportunity next year, for example, to train a Ugandan and a Nigerian physician to go back to be able to understand how they can take what we do in North America and take it back. But I think if each individual identifies something they might want to do, there are lots of ways to connect people during travel or to sponsor people to come and see. And I think that, there are almost 500 people in this room. If half of you decide to go somewhere where you might want to also tag on an educational component to your travel, you would make a huge impact.
Is there some way to do that with the help of the ISN, to do that networking?
Yeah, if you contact the ISN, they'll actually if you tell them what country you want to go to, and if you're having, then they can actually set you up with who the right people are to contact there.
On the theme of sort of getting our local house in order, there's a couple of questions about funding in North America, and if a current funding model, how that might impact willingness to engage. Can we participate in clinical trials? Can we do better?
It's a great question. So one of the ways to answer that is in Canada, with a bit more of the universal care, there shouldn't be any disincentive, although time is the disincentive in Canada, I think, to enroll people. It takes more time to enroll them in clinical trials than just to go and do rounds in the dialysis unit or go to your clinic. It takes an extra bit of time. Most of the clinical trials are set up so that we actually have someone else helping to do that, but you still have to make the time to understand the trial and identify the patient. So in the US, there are some perverse incentives in that the institutions and the physicians get some payment for enrolling in clinical trials. And that's a different model, but again, within a given unit, efficiencies and effectiveness might get impacted by enrollment. On the patient side of the house, if you're in a clinical trial, you get double care. So there's a lot of data to suggest something called the Hawthorne effect. So even if you don't get the intervention and you're in the placebo group, you still get better care and have a better outcome than your colleagues who are not in the trial. So I don't know that we have a good enough way of socializing that to patients. So it's not just about you get the treatment, you don't, but you're going to get better care irrespective.
There's another question that's working its way up the ranks here, and that's maybe if you could come up with, if you can select one or top few, something that you've learned in a practical sense about how kidney care can be delivered in developing countries that was surprising to you. Maybe a particular problem, a challenge, or a takeaway
So
learning
the
point?
thing that I was most, it's a great question. So the thing that I was most struck by in a couple of places, and I had the really amazing privilege of visiting both Thailand and Sri Lanka a number of times, they've set up a real hub and spoke model where it's not medical practitioners or nurses, but rather a village champion in smaller communities that are helping to do the screening, triage and treating, and then actually where people are identified who are less well, then they get moved up, so you don't have to bring all the resources or bring the people to the big cities, which they can't afford, normalizing it so that it's an elder or a village champion who's doing this and not necessarily a medical person. I think most of us would agree that doing a blood pressure and dipping a urine doesn't require a degree. And so in countries that have not a large workforce, that's what they've been doing, and I've been really impressed. So Sri Lanka, Thailand, and I think in China, they have a similar model, and they're using not even iPhones, just phones to actually text the answers back and forth, and sugars being elevated. So I've seen interesting technologies, really simple, of ways to actually help identify and treat people.
Yeah, as we're having this discussion, I was thinking that exactly, that there's a diminishing number of people in the world that don't have access to a smartphone now,
Yeah.
and what a tool that could be to report back, if that could be systematized some way.
Yeah, in China, they had a big $2 million grant from the government to actually systematize the smartphone. This is mainland China, to systemize the smartphone response to hemoglobin A1Cs and urine ACRs. So.
Is that something that ISN might be interested in?
Yeah, ISN can facilitate, but we have our own problems at home. We just heard about the problems with the North and rural and remote and North Island. I mean, I think we could do some of this here as well. It doesn't always have to be, if you think, we're working with some of the indigenous communities to see if we can get elders or people within the communities to do some of this. Point of care machines are going to change the way we do things. And there's a whole effort to really get point of care machines in lots of places that might actually be able to help with self-management and community wellness. Yeah. Right, thank you for your attention.